Bracing, certainly similar for all these ailments. We talked about that a little bit. Can you go to the next slide, please? Certainly there's some elegant different splints that are out there. You can go to the next slide. I think it's a little bit overkill, but it's pretty pretty wild. Next slide. So the main arthritic conditions that we'll talk about, slack wrist and snack wrist. Of course, scapholunate advanced collapse deals with rupture of the intrinsic and extrinsic ligaments, the scapholunate ligaments. Once there is static widening and a DC deformity, there's a risk of the patient going on to a predictable pattern of arthritis that has been described. And of course, snack wrist is similar, except this is certainly a scaphoid non-union. And of course, capitolunate arthritis is always discussed as far as one of the test questions, and we'll talk about that in just a second. The next slide. So slack versus snack. One of the typical questions you get is the answers is the lunate facet is spared in slack wrist due to the forces on the wrist. If there's a capitolunate arthritis, usually a partial wrist fusion is preferred, a four-corner fusion with scaphoid excision. And if the patient's a smoker, generally a PRC is recommended, which is most of my patients. So I generally end up doing a PRC on most people. And certainly it's difficult to get these to heal anyway, and then you add smoking onto that, and it's very difficult. So next slide. So I like to think of the wrist as kind of these, you see these tensegrity tables, So it's pretty unbelievable the way the wrist is held in tension and compression, even in a proximal or distal row versus the rows balancing each other. So next slide. So the predictable pattern was mapped out, I think, in 84. And basically it moves around the wrist. So the type 1 is, radial scaphoid arthritis with some radial styloid beaking. And then the 2 extends to the scaphoid, radial scaphoid facet there. And then, of course, 3 moves into a capitolunate arthritis, and 4 is a pancarpal arthritis. So next. So lots of treatment options. Denervation is an option, particularly for some patients that don't want a more definitive surgery to be done with bone and correction. PRC, we talked about partial wrist fusion, either capitolunate fusion with scaphoid excision, or a four-corner fusion, three-corner, four-corner fusion. Certainly a total wrist fusion is an option. A wrist arthroplasty is something that's becoming more common. It's not a great option for most patients due to the weight-bearing restrictions. And certainly the wrist has to be already well balanced, because if the wrist is not well balanced, there's certainly a risk for dislocation. I haven't done a ton of these wrist arthroplasties, a few of them in fellowship, but I know there are lots of people that are attempting to are using those more and more. And of course, a distal scaphoid pole excision is a possibility as well for a snack. Next. So Wilhelm described his technique for denervation of the wrist. Involves multiple incisions. I think the classic one involves a pretty large U-shaped incision on the volar wrist. It's pretty somewhat, it's a higher morbidity surgery, I would think, as far as the soft tissue goes. Lots of people tend to do the AAN, PIN resections instead of doing the full multiple incisions around the wrist. There's variable results with denervation. Some patients get a lot out of it, some don't. There's a lot of controversy as far as, creating a Charcot joint, which hasn't really been proven. There is perhaps a risk of increased degenerative change. And of course, there's a lot of papers on impaired proprioception. Does interrupting these nerves that go to the wrist capsule cause some sort of issue? It's been extensively studied, and I think the consensus is it doesn't necessarily do that. So a lot of people will add that into their wrist fusions, like a PA anerectomy. Next. So of course, PRC is a very common operation. Good operation, has been around a long time. I tend to add a carpal tunnel release with most of my procedures in patients if they've had any symptoms of carpal tunnel previously, or certainly in unreliable patients, I'll do a carpal tunnel release because I have seen acute carpal tunnel syndrome, and it's a devastating thing to have. So not necessarily with just PRCs, but any of these major wrist surgeries, I'll definitely consider it. So the surgery itself, you're going to release the EPL and transpose it. Most people transpose it. You go between 2 and 4 and down onto the wrist capsule. You certainly want, when I'm doing a wrist surgery, I always you want to identify the EDQ as well. So you want to make sure that all your compartments are identified, so you don't inadvertently cut a tendon. There's a newer way that's I think it's newer, that is weird, opening up distal to the retinaculum. So I'm actually not opening the retinaculum anymore to do the PRC, and it's certainly a much smaller scar, and you can still get to everything, but you just have to be careful with the EPL and the EDQ to make sure you don't damage those. Next. So you can do a ligament sparing, or you can do a T-type capsulotomy. I do a inverted T-type because I like the T-type, but I certainly want to have the option to do an interposition. And I feel like with an inverted T-type, you could still do that even if you didn't plan. If you didn't plan to do an interposition and you noted some pretty significant capitate wear, you could still do that. Next slide. So you would want to be careful to not harm the volar ligaments, particularly the RSC, and certainly a radial styloidectomy is a possible thing you would do, depending on if there's impingement at the time of surgery. You don't want to take more than maybe 4 millimeters. You don't want to, of course, you don't want to damage the volar, particularly the RSC. So those are just some things to keep in mind. Next. So a dorsal capsular interposition is a great option for a patient that you're doing a PRC, but you do notice some capitate wear. Certainly, if there's severe capitate wear on the X-ray, I would certainly not consider a PRC. But if you get in there and there's an unexpected bare spot, you can certainly do an interposition where you take the dorsal capsule. I used to take some of the periosteum off the radius, but I since have stopped doing that. But you basically tie your sutures and your dorsal capsule down to the volar capsule and the volar ligaments, and this provides an excellent interposition, and it has good results. So next. So PRCs are a good operation. You retain motion and they have excellent pain relief. There's some question about whether radial ulnar deviation is better with a partial wrist fusion, but overall they've kind of been shown to do about the same. You will get degenerative changes over time with a PRC, and that's been documented. But it's not necessarily set in stone whether it's going to be symptomatic or not. And there's several people with there's many patients with 10, 15 year follow-up without any significant pain, they do have these degenerative changes. So we don't quite understand that just yet. Maybe it has to do with denervation of the joint with the procedure. So next. So partial wrist fusion. It was the plates were very popular for a while. Certainly this is the top left is a perfect example of the capsulotomy arthritis that you always get tested on with this. But the main thing you want to do is you want solid fusion of the bones, and certainly the ulnar side of the wrist is more, or the ulnar carpals are more difficult to fuse in these types of surgeries. Sometimes they're just left out, but these are almost always accompanied by a scaphoid excision to aid in the dart thrower's motion. So next. Pins are always, the tried and true. Pins have been around a long time, very successful. There've been a lot of issues with the plates. There's several papers about that, and not achieving excellent healing. So certainly you could use staples as well. There's lots of good options. Next. The more important thing to do, and I kind of learned this early, doing several of these, but you really want to make sure that the lunate is well reduced, and even if it's well reduced, you want to check it again and again and again, because if the lunate is not perfectly reduced, you run into creating a malunion, and you're going to end up with impingement. And if you do have impingement, then the patient's not going to be happy, and you're going to end up having to move to a total wrist arthroplasty. So you can use K-wires. You can use the K-wire through the radius, which is an excellent way to do it, I think. Even with an SL repair, if you're doing a ligament reconstruction or repair, this technique is excellent for that as well. So next. So this is what I was kind of talking about. So if you malreduce the lunate, you get a kind of a angular deformity, and that creates place for dorsal impingement. So you want to really be careful if you're doing these partial wrist fusions to make sure that's well reduced and you don't have impingement. Next. So total wrist fusion, you're lots of anatomic plates for these. I almost always do a PRC with mine, and I think they do very well. And you got a great supply bone graft. You can also get graft from the radius if you want. I think that's another great option, is getting some of that cancellous bone from the radius if you need it. Next. In this paper, they were very adamant about the CMC being grafted. In my experience, I haven't really seen any issues with not grafting the CMC. I've been with done a lot of these and done a lot of with different surgeons, and a lot of them haven't done that. So certainly it's a great idea in theory to graft that and have one solid bone fusion. But as far as, I'm not familiar with the literature as far as that being a significant issue, but certainly the board answer would be to fuse the CMC joint as well. So I actually tend to create a trough with my radius plate. I feel like it's a radial portion of the plate. I feel like if certainly you want to take the Lister's tubercle, you want to make a nice an area for your plate to sit on the dorsal radius, but occasionally you'll note on the lateral that the radius, the distal radius, will be volar, prominent volar, and you really have to be careful not to create an issue where your tendons are being strung over this very prominent distal radius, or certainly causing a compression of the median nerve based on your malreduction. So next. So total wrist arthroplasty, I didn't intentionally, or maybe I did intentionally put this x-ray up, but there's certainly a lot of issues with total wrist arthroplasty from, and a lot of those have been corrected over time. The biggest issue is finding a low demand patient that this is ideal for. You got a 10-pound weightlifting restriction. I think most people abide by that. Certainly the best indication for this and the board answer would be someone who has a contralateral wrist fusion. Certainly you want something that retains motion on the contralateral side. Most people will fuse the dominant wrist and then a motion sparing procedure on the non-dominant wrist. Like I said earlier, kind of a balanced wrist with good bone stock is really necessary for this, because if you don't have adequate bone stock, it makes implantation obviously difficult and can increase your risk of instability. If you do find one of these dislocated, the board answer I think is to reduce it and cast them, and to monitor them weekly and as they're casted. So next. So this is just an example of one of those implants. There are several. So next. And then of course distal pole excision. If you do have a non-union, you can certainly try to take out the distal pole. It's a smaller incision, and there have been reportedly good results with that. Next. Certainly don't want to forget about ulnar abutment or ulnar impaction syndrome, or a type 2 lunate, or certainly with a type 2, meaning that your lunate articulates with the capitate and the hamate. There's a risk for a hamate impaction and arthritis as well. So you want to kind of keep that in mind, particularly, that usually doesn't show up on MRI or anything like that. And a wrist scope is usually good for that. Of course, you can certainly see cystic change, but you always think about ulnar abutment, ulnar impaction, and you can see the cystic change there in the lunate, and you want to address that. Next. So certainly, shortening or a wafer procedure even can be done arthroscopically. Next. And of course, DRUJ arthritis, we're kind of moving down or moving to the next topic. So next. So you can do a DERA, which is on the left, where you take the ulnar head. You want to take enough that you're not still in the DRUJ proper, and you can get convergence and notching of the radius. It can be very painful, especially with power grip. The bones converge. This is a hemi resection with interposition. Different things you can use for that. One of the more creative ones that I saw recently was a quadratus interposition. Now on the right, there's a suavicapangi, which is mixed, I would say, as far as the literature. Some think they do terrible, some think they do okay, but you fuse the DRUJ and you do a resection. Certainly with those resection procedures, you worry about ulnar stump instability. You can do a super DERA, where you take more of the ulna and move that up proximally, but there's still a risk of convergence there. And then if you ever get to the point where you have convergence, the HOS operation is a good option as well. Ask your attending about that. So you can do an ulnar head arthroplasty, which have pretty decent results if you have an intact TFCC. And this is the Schecker implant here on the right. DRUJ replacement has a little plastic ball in there that provides the rotation. That's it's a cool implant, very expensive. The interesting story, the guy actually funded himself kind of privately, so pretty interesting. Next. So moving to the MCP joint, certainly you can, I have most experience with silicone, and that's what I used in fellowship and residency, and pretty much all I use. And some people use pyrocarbon, which can be a good option if you have a relatively good bone stock. And of course, fusion procedure is a good option for pain relief. Certainly, their motion is non-existent at the joint after you fuse it, but It's the best option for significant deformities we'll talk about later. Next. So this is just an example for some severe MCP arthritis. You've got some K-wires in the PIP joint there. So next there. So this is, if you're doing these surgeries, generally, if you have significant bone loss, the silicone arthroplasty is I think the best choice because it's able to compensate quite a bit. Some of the other implants, the non-silicone implants, need more bone, is what's kind of described in the papers, the review papers. So I tend to kind of gravitate toward the silicone. Next. So it's just another example of some MCP arthritis and primary osteoarthritis there. Next. So, and that's an example of a power carbon. I don't have a ton of experience with the power carbons, but it certainly is a good option. Next. The biggest issue with the silicone arthroplasty, you see the grommets here, so those are optional. I haven't seen them used very much as far as using the grommets. I don't typically use them, but certainly the biggest issue you have is implant breakage, and that's something that's very high. It can be up to 60%, after 3 to 5 years. So one of the biggest things you want to look at with implant breakage is if you have a sudden increase of range of motion, particularly with flexion, up to about a year or after a year, that's a very high indicator for the implants broken. So you really want the patients to, this is not an operation that's done for a full range of motion. This is for functional motion, and even pushing flexion too far can certainly put this at risk for a breakage. So next. For the thumb MCP joint, the most common operation is a fusion, usually with a tension band or a screw. There's so much motion at the CMC joint that the MCP joint is not having it fused is not as big of a deal, and it's excellent for pain relief. Next. The PIP joints. So these are the Heberden and the Bouchard nodes. I kind of tend to remember those by the alphabetical order going from proximal to distal. So the Bouchard are more proximal, the PIP joints. But as far as PIP joint arthritis, I think either fusion or silastic implant or silicone implant are the, in my opinion, the better options. Certainly, you can do power carbon, but I think the results are very good with the fusion and silastic. Next. So this is an example of pretty severe PIP joint arthritis. One thing you want to definitely note, and then when you discuss with the patient, is any of these joint replacement procedures, you will not correct the angular deformity with that. So the only way to correct that is with a fusion. So what happens is a lot of times these deformities recur after surgery with a joint replacement. Next. So you can also do, interposition of some sort. There's several. I was on a paper where we did a dorsal capsular interposition. Lots of different options with that for someone that you want to stave off doing a arthroplasty. So, but the more common one is the volar plate, where you take the volar plate and you suture it dorsally. Next. And the cascade of the fingers is what you're trying to replicate. So you want your fusion position, if you're fusing the PIP joint, to mimic that. And of course, the PIP joint is very important for bringing the fingers into the palm, and that certainly won't be ideal. But you're doing the surgery for pain relief. So particularly with the index finger, you want to consider very strongly fusing the PIP joint. Because there's a lot of stress at the index finger with pinch, and a lot of times those arthroplasties will have a higher rate of failure at the index finger PIP joint. So you can certainly do pins, tension band, screws. Any of those are good options. The biggest thing is the volar or the dorsal approach. You go to the next one. So you can either do a central incision, or you can do kind of, oops. Or you can try to spare the central slip. So the dorsal incision, am I limited, doing several of these, but not hundreds. When you do a dorsal approach, they do not tend to have an excellent extension with that central slip being violated. The volar approach is the approach where you shotgun the PIP joint. You have to take down the collaterals to do that, and you do a resection. And I think it's an excellent approach for this. You can also use that for a hemihamate procedure if you're doing that. So next. So different options for this: certainly the silicone, the titanium polyethylene, which is misspelled, and the pyrocarbon are all different options with different limitations. So I don't have a ton of experience with the titanium or any of those. I've mainly just done the silicone. So next. Certainly with a DIP joint, fusion is I think the gold standard as far as arthritis of the DIP joint. There's been several studies where they simulate a fusion and at the DIP joint, and there's no difference in functional outcomes. You want to fuse the joint about 0 to 5 degrees, particularly at the fingers, and your goal is a solid fusion, and I generally do very well with that. So you can do K-wires, which I've done for trauma patients with no bony support. Just put some K-wires across like a thumb IP joint, and they heal. And you take those you can even take those buried wires out. Of course, IM screw is the real popular way to do it now. You can do a tension band. I think it's a little overkill for a DIP joint, but when you're doing an IM screw, you want to be really careful, particularly with the mismatch of putting the screw in. A lot of times distally in the distal phalanx will be pretty tight, and then there won't be a lot of fill in the middle phalanx. So you maybe want to put a derotational pin in, which I will do if there's rotation or instability there, and you take that out in the office. The buried pin, 8-10 weeks, something like that. When you have good fusion, that is no pain, so not a big deal.